To finish off this respiratory unit, we need to look into homeostatic imbalances. First one up is COPD, chronic obstructive pulmonary disease. Now, COPD a lot of times is characterized by chronic bronchitis and emphysema. Quite often, those go kind of hand in hand with COPD. Doesn't mean that everybody that has chronic bronchitis or emphysema has COPD, but quite often they do go together. Now, COPD is the irreversible decrease in the ability to force air out of the lungs. Now, if you think back to, we talked about those different pulmonary tests. FVC, forced vital capacity, FEV, forced expiratory volume. Those are ways of testing for how much the lungs are still compliant and how fast you get the air out of the lungs. So a lot of times those are used in conjunction to seeing where the patient is in these cases. Now, some other things that usually go along with COPD. I have down here about 80% of patients have a history of smoking. Smoking is going to be a very large risk factor heading into COPD. You can also have dyspnea. Dyspnea is kind of like air hunger. You're gasping for breath. You're trying to pull air in. You just don't seem to be able to get enough air into your lungs. Coughing, frequent pulmonary infections can also be a kind of telltale sign leading into this. And then a lot of times they're going to develop respiratory failure later on in COPD. So it's kind of progression as you go through. And at that point, respiratory failure starts to kick in. It's harder and harder to get your breath, harder and harder to breathe. So kind of looking at this, it's kind of like a visual overview of what we just talked about. Looking at emphysema on one side, you're breaking down the elastin in the lungs. The lungs won't recoil as efficiently. It's harder to exhale, harder to get the air out. Therefore, it takes longer to get the air out, and then longer until you breathe in again. You have chronic bronchitis. In this case, you're looking at irritation, inflammation of the bronchi. Together, they can both be present and causing airway obstruction, trapping, dyspnea, a whole lot of different problems here. Ends up in hypoxia. So you're basically having problems getting air in, therefore lower oxygen levels in the blood as well. Another homeostatic imbalance is asthma. Now, asthma has a huge range depending on what's going on. Sometimes individuals have more of a mild case. Sometimes someone can have a very severe case. But overall, the whole grouping of asthma here, a lot of times looking at wheezing, chest tightness, coughing, dyspnea, it's basically characterized by trying to get air in and having a very hard time doing it. Because what's occurring is inflammation of the airways is happening. And this inflammation usually closes down the airways, making it harder for air to flow in to get to the lungs. And this can precede a lot of times brachial spasms. Now, these bronchial spasms can cause the air itself, the air passages, get even smaller as a spasm closed, making it harder to get the air in and harder to breathe. Now, what's causing this a lot of times is the release of interleukins. They're produced by the IgE antibodies, which are supposed to help you, but in this case, they're not being very helpful. So they're recruiting inflammatory cells, saying, hey, we've got problems here, cause inflammation. The only problem is the inflammation is what's actually causing the problem. So this response here is what causes the inflammation to occur, causing the airways to get smaller, making it harder for air to flow in. Now, as the airways thicken because they're inflamed, you also then are going to have this exudate, basically a secretion, that can go in and make it even harder to get the air down. Because not only are the airways thickening and inflaming, you have a secretion, this exudate going in, making even less space for the air to flow through. In extreme cases, in very bad cases, the airways can completely close off in some individuals. If that happens, there's obviously some very serious problems because you don't have the air reaching the lungs. Next one in the row here is tuberculosis. Tuberculosis is going to be caused by a bacteria referred to as Mycobacterium tuberculosis, hence the name tuberculosis. Now, this bacteria is really pesky to get rid of. It can be gotten rid of, but it takes a 12-month treatment of antibiotics to get rid of it. That's why it's one of those things that if you can do anything to keep yourself away and not get tuberculosis, save yourself a 12-month hassle of basically going through antibiotics at this point. Thankfully, though, at least for the majority of these tuberculosis cases, the person can recover, getting away from this fever, the night sweats, weight loss, this horribly obtrusive cough that constantly is basically the whole body feels like you're coughing. So by going through the treatment, more often than not, it's able to remove the bacteria from the lungs and from the body and clear that up for the person. Now I say mostly because some cases are a little more resistant, unfortunately, and don't respond to the same normal 12-month course. And then we have lung cancer as the last one here. Now, lung cancer isn't just one thing, it's a grouping or series of different cancers. Now, lung cancer, 90% of cases are usually coming from smoking as a background. Now, does that mean that everyone that has lung cancer smoked? No, that's why it's 90%. But it could also be secondary hand smoke if you lived in a house where somebody else smoked for years, or you're always constantly around the smoke as well. But a lot of times there's a history of inhalation of cigarette smoke at this point. So there are three different types we're looking at. There's squamous cell carcinoma. And I have down here 20 to 40% of cases. But it's in the bronchial epithelium. So the cancerous growth, this uncontrolled growth, starts in the bronchioles, in that epithelial tissue, so the very inside layering, which makes sense if you think about it, because the epithelium is what comes in contact with that smoke that's passing by. Next up is the adenocarcinoma. It's give or take maybe about 40% of the cases. This one is usually in peripheral lung areas, so further out in the lungs, and then kind of works its way back. And then we have small cell carcinoma. Because this one's not as common, about 20%. This one is lymphocyte-like cells originating up in the primary bronchi. So trach comes down, primary bronchi that split. You have these cells originating right there. And the real problem with this one is it quite usually metastasizes. Metastasizing means it's going to start in one spot and then spread throughout the blood. So therefore it goes into other places and can pop up in, the liver, it can pop up into the intestines, wherever. So 3 different variations, but they're all classified as lung cancer. Now you don't need to memorize percentages, but have an idea of what each one is here. From bronchial epithelium with the squamous cell carcinoma, to your adenocarcinoma more in the peripheral areas, and the primary bronchi with your small cell carcinoma. So there's a little bit about homeostatic imbalances to wrap up the respiratory system.